are similar in one important respect, that they all emphasize that lowering blood pressure is important for a large proportion of the population, whether it's China, Japan, US, or Europe. The question is how low to go. The US has been the most aggressive, probably, relying on evidence from randomized controlled trials, particularly the most recent SPRINT trial, systolic pressure intervention trial, which showed in patients who were carefully screened and carefully followed for an average of 3.5 years, that randomization to a systolic blood pressure goal of 120 was better than to a goal of 140 in preventing all kinds of cardiovascular outcomes, the composite of stroke, myocardial infarction, heart failure, kidney, kidney deterioration in kidney function, and death. So on that basis, realizing that the clinical trial setting is a little bit different from the ordinary patient setting. In the clinical trial, the patients had been in for several years. They had visits every 3 months. They were familiar with the coordinator. So they were very relaxed in the clinic. And it was easy to achieve a blood pressure of close than 120. In a busy clinical practice where you're in a hurry, the patient's in a hurry, the patient may have other complaints, some pain or something. It's very difficult to do that. So on that basis, the Guidelines Committee in 2017, the ACC-AHA Guidelines Committee recommended a target of 130 over 80 for most patients. This is in contrast to the old 140, because the SPRINT had shown that getting lower is better. I think in other settings where the background is different, the clinical trials may not be there, it might be reasonable to have a less aggressive goal because it is possible to do harm by lowering blood pressure too much. I think it is very important. Out of office, instead of calling it home, I would call it out of office blood pressure monitoring is very important. Measurement is very important because the office setting can be very artificial. Some patients are very nervous. There's the white coat phenomenon, which they're falsely elevated. So if you manage by the clinic blood pressure only, you would be treating too aggressively and could cause harm. But there's also the masked hypertension, which is more serious. Masked hypertension means your blood pressure is elevated out of office, but is under control, whatever the control level is in office. And those patients would be missed if we used only in-office pressures. And it's been shown that those people have bad outcomes. So it's important to have some out-of-office blood pressure measurement. Now, the question is how to do it. Some people say we need ambulatory blood pressure monitoring with the cuff on for 24 hours, measuring the pressure every half hour or every 15 minutes. That's nice, but it's very expensive, costly, and some patients don't like it because they can't sleep very well. It's better if you can teach the patient to buy a good blood pressure cuff and then measure the blood pressure when they're relaxed, sitting for 5 minutes, not talking, not drinking coffee or tea, not arguing with the spouse, and can get an idea what the blood pressure runs. That's very valuable. And some studies have shown that home blood pressure measurement with a reliable, by a reliable patient is better than the ABPM even. So that's very important, but it's a educational challenge. And there's also a cost of buying the machine. So we have to work that out exactly how we're going to do it, exactly what kind of equipment is going to be used, exactly what sort of schedule we have. That's very important now that we have the pandemic. I see patients 1 day a week, all day, and many of them cannot come to the office because they haven't had inoculation against the COVID-19. So that we're doing home visits. And so I have, the only measurement I have is what the patient records. So it's very important to get that into the education system in the care of everybody with high blood pressure. That's a great question. Well, the whole process, meaning the natural history, I think that we should have, in young people, even children, should have blood pressures measured, by their provider. And it's been shown that the blood pressure tracks. If it's high when you're a child or an adolescent, you're going to develop hypertension when you get younger. And the hint is also, if you have a strong family history, if your grandparents and parents have high blood pressure, you're probably going to inherit it. What you can do about it, is try to avoid those factors which make the hypertension worse. That is, don't eat too many salty foods or fatty foods. Don't get fat. Obesity in the US is a huge problem, and it contributes to hypertension. Also, physical activity is much underrated. It's known if you are active, you stimulate nitric oxide production in the blood vessels when the blood goes past the endothelial cells, and that's a vasodilator. So that physical activity as well as diet are important in the prevention of hypertension and in the potentiation of the drugs. We don't advocate, if you know you have high blood pressure, we stick you on 2 drugs and you can do whatever you want. You should continue to be physically active, continue to keep your weight down, continue to eat a healthy diet. All those things are important. And that's through the lifetime, from the time you're a child till the time you're 90 years old. So these things and that's a great question too. It's the whole process. And so that people don't get afraid. Sometimes people are very afraid of the diagnosis. It can be managed. And in most cases, we can keep people from dying and keep them from getting. Now the major complication is no longer a stroke or heart attack, it's heart failure, because people are living longer with high blood pressure and they get heart failure with preserved left ventricular ejection fraction. We want to avoid that. So all those things are important. Well, that's a great question. There are studies, and I'm collaborating in one of them, in underdeveloped poor countries like in the Caribbean, Puerto Rico, and related islands, where there are programs to screen the population so you don't have to go to a doctor. You can have screening programs where the people are screened by health care workers, and this is paid for on a grant. And then if they're found to be hypertensive or borderline hypertensive, encouraged to do the better diet and do more exercise, and given very inexpensive medications, frequently fixed dose combinations that are cheap, can be very helpful. So that population basis, in poor countries, a population basis type of approach is very important. You can't expect somebody to go to a doctor that charges you $50 every visit, plus the medicine, plus other things. So we do need population-based approaches. And that's true not only in poor countries, but it's also true in parts of the US, even the richest country, which are poor. For example, I'm involved in a study in rural Alabama, the state of Alabama, which has a lot of African-American people and lower socioeconomic status people, and people who live in the countryside. And we try to get them to get their healthcare workers to be more conscious of the guidelines and how to manage the blood pressure and how to use the electronic medical record and so on. And then how to get the patients to be more adherent to a regimen. So it's a team type of approach. The other thing is that there are not enough physicians with a doctoral degree in the world to do this, so that other healthcare workers who are nurses and even interested lay people that are interested in the health and are willing to work with patients, but do not have medical training, can participate in all this at very low cost. So there are lots of different approaches that are being looked at and are needed in order to bring everything under the umbrella of good blood pressure control.